Well, hello, everybody. Welcome to IRG's podcast, Health Matters, Why Do I Hurt? As we've talked before, our goal on this podcast is just to educate our listeners out there about general medical conditions, trauma, surgery, family practice, community health, you name it. We talk about health situations here. And joining us today, we're excited to have Dr. Nicholas Vaudreuil here with us. Dr. Nicholas Vaudreuil, how are you?
Hey, Shannon, doing great. Happy to be here. Loving the holiday season.
Amen. I love to hear it. You have a good Thanksgiving?
Yeah, really nice. We traveled to the Midwest and saw a bunch of family. Had a really nice time.
Excellent. You're an orthopedic surgeon. Tell us what you specialize in. Tell our listeners what area you like to focus your practice. Maybe talk about a little education, a little background, kind of a historical perspective of your journey.
Yeah, Shannon. So, my name is Nick Vaudreuil. I work up in Everett, Washington for Proliance, EBJ, also known as Everett Bone and Joint. I'm a sports medicine orthopedic doc. So, my specialty is kind of minimally invasive arthroscopic surgery with the small incisions. And because a lot of those skills translate over between different joints, I take care of a lot of different injuries for a lot of different joints and conditions. So I do shoulder injuries, elbow, hip, and knee. And I want to be able to treat patients that are, teenagers all the way up through, active people in their 80s and 90s. So I see a good mix.
Would you consider yourself, when you talk about your fellowship, we've talked to a lot of orthopedic surgeons over the last several years, and we hear about these fellowships. Is your fellowship essentially in sports medicine, or tell us about your fellowship training?
Yeah, so for orthopedics, you do your residency, and that's where you kind of get exposed to everything. I did that out in Pittsburgh, University of Pittsburgh, and then I went to a place called Curlin Job Orthopedic Clinic in LA, and it's just a long-standing orthopedic clinic and training fellowship program that's been, it was developed by the guy who was like one of the original team docs for the Los Angeles Dodgers and developed the Tommy John surgery. So they just have had a name in the business for taking care of really high-end athletes and providing really good patient care. I chose that spot because I thought I could get really good training in all four of the major joints for sports medicine. So shoulders, knees, hips, and elbows. Elbows kind of a injury that was unique that a lot of places don't really focus on for sports medicine. So that was something that I wanted to bring to this area.
Yeah. How'd you get interested? Take us back to your interest in orthopedics. Obviously, my world is in orthopedics, being a physical therapist, and orthopedics is very mechanical. It's very three-dimensional. There's a lot of moving parts, so to speak. I mean, you have to know angles and degrees. I mean, there's a lot of thought process here. It's almost like an orthopedic surgeon, you're almost putting a puzzle back together at times, right? Where'd that interest start from? How'd you decide on orthopedics?
So I think I was a big jock in high school. I played football, wrestling in high school, football, wrestling, and lacrosse. And, I had little injuries here and there, and I did a lot of therapy. And I thought I wanted to be a physical therapist for a long time. That was kind of the route I took going into college. I played lacrosse at Gonzaga on their club team.
Okay.
And I got injured playing lacrosse. I injured my elbow and had to have surgery for it. I had basically a cartilage injury and a bunch of little pieces that broke off, and I ended up having to get a surgery for that. And I kind of just clicked with my orthopedic surgeon in Coeur d'Alene, Idaho, where I grew up. And, I got to get exposed to that world, and I shadowed him and just kind of fell in love with it. It just fit so many of the aspects of my personality, and that was kind of what drove me to go to medical school.
Yeah, what would, if you were to tell our listeners, give us a day in your practice. What does that look like? I'm sure you have office hours, and then you have, what would you call clinic, and then you probably have surgery days, but just give us a typical day, what that looks like.
Mm-hmm. Yeah, it's going to be different for any surgeon you talk to, even within orthopedics. Some might have almost all days in surgery, some might have very few. Mine is a good mix, so I definitely see a lot of patients in clinic just because a lot of sports medicine conditions can be treated without surgery. So it's about sort of navigating that process for people with different medicines and physical therapy programs and injections. So I'm in clinic usually 2 or 3 days a week, and then I'm in surgery the other 2 days, doing a mix of the arthroscopic surgeries or open surgeries, depending on if there's fractures that came in or tendon injuries or what I might see. and I mix in injections throughout kind of my clinic days. We do cortisone injections and PRP injections pretty regularly.
Yeah, you're being kind of humble here. Just to go back to your fellowship here, I had the good fortune of going to graduate school in Los Angeles. This is in the mid '80s. That's for you listeners out there. I'm talking about 1980s. Yeah, I know I'm an old guy, right? And the Curlin Job Clinic, I mean, it was well respected, world renowned. Everybody wanted to go to the Curlin Job Clinic to get some kind of experience. I mean, it's a well respected orthopedic institute right there off when I was there, it was off 210, the freeway 210, and it was a really cool place, and that's where you did your fellowship, and that fellowship was one extra year in specialization, all those joints you just talked about, shoulder, elbow, hip, and knee. So I mean, it's very, very specialized training. How many during that year? How many surgeries do you think you perform in that year in a fellowship? Just out of curiosity.
Yeah, I kept track at one point. I think it was between 500 and 700, something like that.
Yeah.
They keep you moving for sure. We worked with a bunch of different people, and we covered sports games and all that.
Think about that for our listeners there. That's a lot of training. That's what that fellowship training. So Dr. Vaudreuil came out of school, out of fellowship, highly skilled, highly specialized, and that's what we're going to talk about, an area today that you probably work on quite a bit, and that's clavicle fractures. And we've seen, particularly with contact sports, people falling off bicycles, traumatic accidents and stuff like that, people fracture their clavicle. Let's talk about the clavicle. What is it? Where's it at, mechanically speaking? Give us the rundown on the clavicle bone.
Exactly. Yeah. Clavicle fractures are pretty common here just because we got a lot of active people out doing fun stuff, riding their bikes, dirt bikes, or just kind of having bad falls. So the clavicle is also known as the collarbone, and it basically is the long sort of tube-like bone on the top of your chest that connects your chest wall to your shoulder. And, these injuries usually happen from like falling or having a direct impact on the outside portion of your shoulder, but it can happen from a lot of different ways. And the most common spot that these break is right in the middle. There's a spot in the middle portion of the clavicle where it's not wrapped around with, attachments for different muscles. On the inside portion and sort of the outside portion of it is. So right at that spot, it's very skinny and it's sort of exposed, and that's where it typically breaks, and then the forces on it sort of can cause it to shift and go weird places, and that's sort of when we start talking surgery and more involved cases.
Well, just from a mechanical standpoint, it's a very complex bone that doesn't get enough recognition, I don't think, because it's very important. As you mentioned, it comes off your sternum and goes out to your shoulder. But when you raise your shoulder and your chest wall, your rib cages are moving when you're breathing, the clavicle is rotating. It's got some interesting mechanics. So when you put this thing back together, or have to put it back together, tell us about the 3D mechanics, because you got to look at how that thing's going to act at the time that you're repairing it, but then down the road, what is that going to look like when that patient is trying to move? I mean, it's a mechanical aspect.
Totally. Yeah. So when we talk about fractures, we want to describe the pattern itself. So you can have a pattern that's sort of like straight up and down, or it can be like a long sort of spiral fracture. And then we talk about it can be smashed into a lot of different pieces called comminution, or it can be, really rotated. It can be really shortened. The pieces can be really far away. So there's a lot of things that we can sort of gain from just even a simple x-ray, which is usually the main diagnostic tool for collarbone fractures. This bone it's interesting because it's right underneath the skin. So, yeah. I mean, I'm sure everybody's seen somebody who has like a really prominent big bump there, whether they've had surgery or not. And it can be an emergency if the skin is really about to poke through with that piece of bone. Those are ones where they kind of have to go to surgery right away. Otherwise, it's kind of less of an emergency thing, but it is something you have to manage within the first couple weeks from injury, typically. So when we fix these, the most common way to fix these is with a plate and screws. And what you're trying to do is you're trying to recreate the anatomy. So you get down to the bone itself and you want to get it lined up the way it was supposed to be. So we want to de-rotate it if it's rotated. We want to bring it out to length if it was shortened. And then we want to basically limit those forces that it's trying to go back to. Some of the muscles towards the neck are trying to pull it up.
Oh, yeah.
And some of the forces, some of the muscles in the weight of the arm are trying to pull it down on the other piece. So basically the plate allows it to sort of neutralize those forces, and then we want to get good contact between the edges of the bone too. So that's kind of what the screws do, is they hopefully can just hold the pieces of the bone together, and then the plate neutralizes all those forces so that your body can do its thing and then heal it.
So it takes me back to my childhood. They're growing up in the playground on the swing sets. The big swing sets that you tried to swing, and then one day someone said, "Hey, let's get this swing set going. Let's jump out of it." You know what I'm saying? And see how high we can get. And, I think we had 2 or 3 that school year. I think we had 2 or 3 kids with clavicle collarbone fractures. And I remember back in those days, they just put them in a sling, right? It was just a sling type thing. So not all collarbone fractures are going to require surgery. Maybe talk about how you grade these fractures, and don't jump out of the swing. Okay, so
yeah, totally.
Yeah,
that's a great point. And the pendulum is always swinging. I think for a long time, a few decades ago, like almost none of these were treated with surgery, and I think people had issues just from them not healing right, and that's kind of the risk for certain patterns. It may not heal right, or it may heal in a very sort of deformed position. But then, I think there was a pattern for a long time amongst orthopedic docs where we were probably operating on too many of these, and then a lot of people ended up, either having irritation from the plate or, other complications that can rarely happen with these. But to answer your question, a lot of these can be treated without surgery. If the bone is not shifted, then that's a really good indication that this thing is going to heal. The bones want to heal if they're close to each other and if they're touching each other. The real problem is if they're very shifted away from each other, and especially if there's interposed or muscle or layers sort of sitting between them, it's harder for them to sort of span that gap. Your body has to put down little immature bone cells to sort of make it a big sticky ball, and then your body can remodel it into bone. So yeah, if it's really displaced, really shortened, or if there's interposed pieces, or if it's in a lot of different pieces, like if it's really smashed, those can be a lot harder for the body to heal as well.
Yeah, is it fair to say, my understanding also is with technology and some of the material that you're using now, I mean, because that collarbone has kind of a weird, it's just kind of the way it's formed. They used to put, my understanding, they used to put a screw in the end of the collarbone. You can kind of put a screw down through there at times, and the screw would back up from the motion and stuff like that. But now you have these metal plates that you can mold to that shape of that bone, and then you put these tiny screws. Tell us about that, the hardware that you're using. Maybe that's what I'm trying to ask.
Yeah, it's an awesome time to be in medicine. There's just always cool technology coming out all the time. And, the device you're talking about, it's called an intramedullary device. It's basically it's almost like a piece of rebar that you're putting down the hollow part of the bone. And it's become sort of the standard of care for a lot of fractures in tibia and femur in the lower leg. And they were doing it in collarbones for a while, but there was some issues with them backing out and stuff. So I think it's kind of gotten out of favor for the majority of orthopedic doctors, I would say, just because of how successful doing the plate and screws is. The benefit of the plate and screws for this is we use stainless steel typically, and it's got a very high or very similar stiffness with the bone. It's called the modularity of elasticity. I'm probably saying that wrong.
No, of course it is. It's got to be a really easy word. It's got to be
right.
Yeah.
But the bending of the plate is stiff, but it matches the stiffness of the bone as well. So we don't want something that's too rock solid or too soft, or else it can influence what forces the bone is seeing. We do want the bone to feel a little bit of the motion and impact as it heals, or else it's not going to want to send any healing cells there, and you can get something called a non-union, which is where the body just ends up not healing a fracture, even if it's lined up just right. So, we want typically stainless steel. We want to have enough screws that are spanning the gap. We want them in the right spots. And sometimes, depending on the pattern, we'll even use more than one plate. It just, every one of these is a little bit different.
Yeah, it's crazy. Hey, everybody out there, we're listening, and you're listening to IRG's Health Matters. This is our podcast that we talk about different health topics. And today our guest is Dr. Nicholas Vaudreuil. And Dr. Nicholas Vaudreuil is a orthopedic surgeon. If you missed the opening part of the segment, he specializes in sports medicine, did a 1-year fellowship in Los Angeles at Curlin Job. And again, we're talking about clavicle fractures. Dr. Vaudreuil, what's interesting about this is when I mentioned earlier on being an orthopedic surgeon, you just kind of alluded to it. it's very mechanical, the way that collarbone is and how it rotates and moves at the AC joint in the sternum or the chest out to the shoulder. When you're putting that metal plate in there, you can't make that too stiff. I mean, how do you learn that? That's what I'm saying. I mean, how do you get, is that a feel? Is that palpation? Are you taking x-rays? When you get this surgery done, how do you test drive that joint, so to speak?
Yeah. So, we talked about a little bit how the plate and the stiffness of it, we want it to be similar with the collarbone. And, we're lucky to live in a world where we have really nice materials we can use. Different companies make different implants for different fractures or different surgeries you might perform. So a lot of these plates that we use for collarbones are actually kind of pre-contoured to the right shape.
Uh-huh.
There's a subtle sort of like S shape to the collarbone. So whether you're using a pre-contoured plate or you're in there in surgery sort of bending it and contouring it to what your patient might need. There's a lot of ways to sort of get that to be right on the bone. That's the main thing you want to do, to eliminate the forces, because you're right. It's going to see a lot of rotational forces. It's going to see compression. It's going to see pulling. So the main things we look at is that it's solid and it moves as a unit once it's you got stable implants in bone is what it's called, but you got your plates and screws and it's holding it together. It's not wiggling. So yeah, sometimes we'll do sort of pull tests just to make sure nothing's shifting, and we use x-rays to make sure that the screws and everything are the right length, the right location. So there's a few different things we're doing when we're finalizing our last couple screws as that thing goes in.
When you're doing this kind of surgery, let's say you're doing it on, a minor, a 13-year-old patient, right? When you're putting this metal in, is there any kind of concern or any kind of adjustment? Because that bone's going to grow. I mean, they're not fully done growing. I'm talking about someone who hasn't osteophyed yet. I mean, they're still pretty young, so they still have growth plates and things like that. What's the consideration with a young person's collarbone when you're repairing it?
Mm-hmm. Yeah, I mean, everything's a little bit different when you're talking about the growing skeleton. The younger they are, the more growth potential they have. The most common fracture pattern is in the middle, and that's not where the growth plate is typically for collarbones. So they are still going to get growth on either side, and a lot of that growth can help it remodel. So I would say it's a lot more common to treat these without surgery in kiddos, because the healing potential is just that much better, because they're getting active growth and like bone cells kind of floating down that bone all the time. So if it's somebody who has an adult type skeleton, they're almost done growing, they're a high school football player, then we're going to probably treat them like an adult. But for people that are younger than that, it's a lot more nuanced, and you're going to sort of be having a discussion with the patient and the parents.
Right. When you talk about mid shaft fractures, I mean, a lot of times when you talk about that area of the bone, we know in order to heal, you have to have a good blood supply. Does the collarbone in that mid shaft area, is there any concern regarding blood supply when you're repairing these fractures?
Yes, you always want to be thinking about the biology of the bone. You're right. So, we don't want to like have the perfect looking plate on there, but we've sort of taken off all of the muscle and the blood vessel connections to the bone, because you're sort of then like robbing Peter to pay Paul a little bit. You're costing yourself some of the body's innate healing ability to be able to put this plate on there. So you do want to get enough to be able to see what you're doing, to be able to get it lined up the best you can and be able to get your implants on there. But, the clavicle does have a really good blood supply, but you want to be thinking about that too. You don't want to completely strip everything off the bone as you get your plate and screws in.
So let's talk about return to play, healing time. We know a lot of healing is biology. It just takes 6 to 8 weeks for tissue to lay down, and just the biology of healing. Tell us about return to play and healing of these clavicle fractures if you repair them.
Yeah, so in general, I tell people it takes 8 to 12 weeks to heal a fracture. With collarbone fractures, it can be close to 8 weeks if you have like really robust fixation and it's a pattern that you feel happy about how it got fixed. Some of these patterns are just a disaster, and you have to go a little bit slower and let the body kind of have a little more time. But in general, like if you're seeing signs of healing on their x-ray, at 8 weeks, and you've got, their motion has come back as they've worked with their physical therapist. They're out of the sling. They feel like they're getting some strength back, some muscle activation back. A lot of times those people can be assessed to see if they can return to sport, even, especially if it's a low impact sport. But like for, say, like football players, like there's a wide receiver for the Green Bay Packers, Jaden Reed, who's about 8 weeks out from getting his collarbone fixed, and they're like kind of right on the verge of releasing him to play. So
it's amazing. Just amazing. That 8 weeks after that, technology and the advancements in surgical technique. I mean, like you said earlier, it's pretty impressive right now what medicine's doing. Hey, I've heard. I'm just curious. Thinking about advancements, and we're hearing a lot about biologics and things like that. And you being a surgeon, and I've heard of like some surgeons with like certain repairs in the rotator cuff, soft tissue and stuff. Maybe put like a blood patch, or they're doing some kind of biologics in there to promote healing. Is that anything you're seeing in any of your work that you're doing today?
Yeah, the world of sort of orthobiologics, or stem cells and platelet-rich plasma (PRP) is sort of exploding, and there's like basically limitless potential to it, and it's a lot of times it's pretty low risk because you're just taking the material from your body itself,
Right.
And yeah, we're doing that here. We do platelet-rich plasma in my clinic in Everett, and it can work well for chronic tendon issues like tennis elbow, or bursitis issues, and it can also work for some arthritis issues as well. It's not a perfect thing, but for a lot of times it's a good option for people that are trying to avoid surgery, that want to stay active. And I'm excited to see what happens with all of it. It's like I said, it's got basically limitless potential moving forward.
It's moving really fast. I'm excited and somewhat anxious in a way, just to see what AI does in healthcare. You can just see some of the diagnostics, some of the use of AI. I mean, even in your field, when you talk about robotic assisted surgeries and some of the stuff that's going on with, topography and technology and computerization and things like that, I'm sure you're seeing a lot of advancements, and those are tools that you can use probably down the road, or maybe are using right now. Are you using any of that right now?
Yeah, the biggest, certainly the robotics and stuff has been at play in the surgery suite for a while now, and that continues to be really cool. But the biggest thing I'd say nowadays is we're starting to get AI to help with getting history and seeing people in clinics. Like you can have your phone there, and it's basically like an observer kind of listening to the conversation you're having with the patient, and then it'll basically help formulate a lot of your note for you. So it's pretty wild, the stuff that's out there now.
Yeah, well, as a clinician, obviously, you can appreciate just like I can. The least favorite thing you probably like to do is probably be inundated at the end of the day and taking paperwork home, right? And we are all challenged with paperwork in healthcare, and it's so cool because we use a software called Prediction Health here at IRG Physical and Hand Therapy, and it allows our clinicians to be listened to when they're having a conversation with the patient, and then it transcribes it, and then they just hit a keystroke and it drops it into the note, and that's fascinating. And because we've decreased our paperwork time by 50%, which means that our therapist can spend more time interacting with the patient. Isn't that what it's all about?
That's the best.
Yeah, I'd much rather treat a patient than to sit with a pile of charting, right? You know what I'm saying? So
Same.
Yeah. Hey, I want to have you back on because I want to talk to you. I had a call the other day from a young man, and he had some hip stuff going on, and it sounds like he might have a labral issue and in his hip. And I know that when you talk about your specialty in sports medicine, I know you do hip preservation and hip surgeries. Are you doing that?
Oh, yeah, it's near and dear to my heart. I take care of a lot of hips, a lot of labrum tears, and that's another huge topic, so I would love to talk about it.
I want to talk to you just because, when I started in the physical therapy 35 years ago, there was, I don't know, I remember anybody doing hip scopes. I can't recall anybody off the top of my head, at least locally, doing hip scopes here in Seattle. And now there's a handful of folks out there. That's a very, very technical surgery when you look at scoping the hip and how much room you have to get the scope in there and treat that. But I'd love to have you back on and talk about labral tears of the hip. Can we do that?
Let's do it. Yeah, let's sign it up.
Yeah, we
Sounds
will.
Good, Shannon.
We will. Hey, tell our listeners as we wrap up here, thank you very much for your time. Excellent stuff. Hey, a couple things real quick. If I'm a parent or anybody out there and I fall, what are my signs? Real quick, how do I know that I might have fractured my clavicle? I need to, obviously, pain, but tell us what else you might feel as a patient.
Yeah, pain, trouble moving your arm. You might feel clicking at the front of your shoulder. You might see kind of a prominence there up against your skin. Obviously you can get swelling and bruising. So if you got that stuff after an acute trauma, you should be heading to either urgent care or emergency department to get an x-ray, get that thing checked out. Awesome.
Great work. If you want more information, you can contact Dr. Nicholas Vaudreuil at ebjproliancesurgeons.com. That's ebjproliancesurgeons.com. Dr. Vaudreuil, thank you very much for your time. Great job.
Thanks, Shannon. Appreciate it.